A trabeculectomy in a patient with neovascular glaucoma who has uncontrolled intraocular pressure despite being on maximum medical therapy. So we begin by taking a traction suture. In this case, we are taking a superior rectus traction, which has been used. Although nowadays many surgeons prefer to use a corneal traction suture simply to keep the eye in a down roll position. We are performing a phonics based peritomy to create a healthy conjunctival flap for the trabeculectomy. The tenons capsule is carefully separated from the underlying sclera. We try to remove as much of the tenons tissue as much as possible so as to prevent fibrosis in the post-op period and to have a diffuse bleb. The goal is to achieve a well diffused functioning bleb. Meticulous removal of the tenons tissue is essential. After thoroughly clearing the tenons tissue, the surgeon proceed with cauterization. For these, all the scleral vessels within the surgical field are cauterized. A hemostasis has been achieved. Attention is being shifted toward the scleral flap. Commonly used techniques for creating the scleral flap: a triangular flap and a rectangular flap. In this case, we are fashioning a triangular flap. A partial thickness scleral incision is first made to mark the extent of the flap, following which the flap is carefully dissected forwards, taking care to avoid buttonholing or premature entry into the anterior chamber. At this stage, the perforator vessel starts bleeding. Once adequate flap length has been created, the surgeon performs a partial deep sclerectomy to provide sufficient space between the scleral flap and the scleral bed. Depending on the surgeon's preference, a deep sclerectomy may also be performed, and in this case, rather than cutting off the part of the sclera, we are just scraping off the scleral tissue so as to create a little bit of space between the two surfaces. Next step is the application of mitomycin C soaked sponges. We are using 0.02% mitomycin C. However, since this is a case of neovascular glaucoma with a high risk of postoperative fibrosis, the sponges are placed both subconjunctivally and beneath the scleral flap for a duration of 5 minutes. It is important to count the number of sponges which are being kept so as to avoid any inadvertent remnant sponge in the subconjunctival tissue. Make sure that they are thoroughly washing off the surface after removing the mitomycin C sponges, as mitomycin C is toxic to the intraocular tissues. Now we proceed with the formation of the ostium. In this, ostium is fashioned using a keratome. All the surgeons prefer to use a Kelly sponge for this procedure. During ostium creation, there is a slight premature entry into the anterior chamber. The surgeon carefully excises a sufficient amount of the iris tissue to prevent future blockage of the ostium. Once it is confirmed that the iris is falling back appropriately, a small hyphema can be noted due to the blood entering the anterior chamber, which is not uncommon in neovascular glaucoma patients. So, after the iris has been cut, a surgeon has injected some amount of pilocarpine into the anterior chamber so as to make the iris tissue fall back by the insertion of air bubble into the anterior chamber. Now, the scleral flap is sutured with the help of a 10O monofilament nylon suture, and the first suture is being placed at the apex of the scleral flap, and we have to make sure that we do not make the sutures too tight or too loose. Too tight sutures will make the procedure fail, as there'll be a amount of apposition which will be present between the two surfaces, and too loose suture will make it leaky so as to have a hypotony in the immediate post-op period. So we have to balance between these two. Next, the surgeon is for giving an interrupted side suture on the side of the scleral flap, and here also the surgeon is constantly checking the tightness of the suture. Then it is followed by the use of an releasable suture, which in which the first pass is made through the conjunctiva on the opposite side, and then the second passes through the scleral flap and the sclera adjacent, and it is followed by the formation of a releasable knot. This releasable suture is intentionally kept slightly tighter to provide better intraocular pressure control during the immediate post-op period. This suture can be later removed easily by the slit lamp if additional filtration is required. Then the sutures are buried into the sclera, and the patency of the ostium is seen by injecting some amount of BSS into the anterior chamber. Once satisfactory filtration is confirmed, the conjunctiva is closed using continuous locking sutures. So we are making sure that we achieve watertight suturing in this case so as to avoid hypotony in the post-op period. The water tightness of the suture is being is confirmed by applying some amount of fluorescein strip, and then followed by injection of any intracameral substance, like in this case we are injecting moxifloxacin, and then it's followed by the injection of subcon